Hello friends, and welcome to the next lecture in the series of Rapid Revision in Orthopedics by Dr. Prateek Joshi. And our topic for today is infections in orthopedics. Now, infections in orthopedics spans the entire gamut of all infective etiologies in ortho, and that includes acute as well as chronic osteomyelitis. But acute and chronic osteomyelitis together is quite a large topic, and therefore in this lecture we will keep it only to acute osteomyelitis and some general considerations regarding osteomyelitis or bony infections. Now, before we start, you may find that a couple of slides are very theoretical or there is a lot of text on one slide. Now, these are carefully curated keywords which have been compiled from standard undergraduate and postgraduate textbooks of orthopedics, and these are the words which you would like to mention in your theoretical answer or in your viva voce examination. So as in when you get a theoretical slide, please feel free to pause the video and screenshot it, or even better is to write down those keywords. They will help you in your future revisions. Now, before we actually start for real, the name of the channel is Rapid Revision in Orthopedics by Dr. Prateek Joshi, and if you have not subscribed to the channel as yet, please subscribe and please hit the bell icon so that as and when I put up some new content, you can get it directly. So, starting with general considerations and acute osteomyelitis. Now, infections in orthopedics are generally very severe, sometimes limb threatening and sometimes even life threatening. Now, there are some reasons as to why this happens. The first one is that orthopedics essentially involves deep spaces, which means the deepest tissue of the body is the bone. The only thing deeper than the bone is the medulla of the bone, and some other places such as abdominal cavity or cranial cavity. And because of that, an infection in orthopedics is essentially a deep infection. Deep infections are more difficult to eradicate. They spread and become systemic much faster, and they can be more life-threatening. Also, some authors are saying that the incidence of antibiotic resistance is a little more in deep infections. Secondly, now especially in growing bones. In growing bones, there is a very high degree of vascularity, especially at the epiphysis and the metaphysis and the epiphyseal-metaphyseal junction. The density of blood vessels in this area is among the highest in the entire body, and so is the blood supply because of the rate of growth. So this affects the propensity for infection in two ways. First one is that because of this entire increase in vascularity, the amount of blood turnover in that area is much more, and therefore the amount of circulating blood and circulating blood components in that is much more. So in the presence of bacteremia or septicemia, there will be more delivery of the infective agent to the metaphyseal or the epiphyseal end of the bone, because of which the propensity for infection is more. Also, the other side of this is that because of this same increase in infection, in a de novo infection of the bone, it is more likely to spread and become multifocal, or a localized infection is more likely to become a bacteremia or a septicemia because of this rich vascular supply. Moving on, if we have seen the earlier video about pathophysiology of trauma or pathophysiology of fracture, you will know that every trauma incites a local inflammatory response in the bone. This inflammatory response is it is heralded by interleukin 6, interleukin 8, tumor necrosis factor alpha, and many other inflammatory mediators, because of which we will have increased vascularity, increased vascular permeability, and because of that there will be increased transudation of fluid into the third space, which overall increases the delivery of the infective agent into the most vascularized area of the bone, which is metaphysis, epiphysis, and the epiphyseal-metaphyseal junction. Also, there is anatomical factors in the vascular bed which promote the presence of infection there. I have a separate slide for this, so we shall talk about it when we come to it. Also, post-traumatic infections cause deep contamination in three ways. First one is that the compound fracture in itself is an invitation to infection. Now, in our slide on general terminology and concepts in orthopedics, we have discussed compound fractures, which is a fracture which communicates its hematoma to the external atmosphere through a wound which has been caused by the fracture, and therefore through the overlying skin and soft tissue and the broken bone, the hematoma and the bone marrow of that bone is directly in communication with the outside atmosphere, which gives it a track to infect. Secondly, if you have closed fractures which are complicated by compartment syndrome, then in this case Compartment syndrome will have to be treated by fasciotomy, which involves opening the muscular envelope around the fracture and exposing the fracture site to the atmosphere, again creating a pathway for infection. Thirdly, in any fracture treated by external fixation using shank spins and the connecting rod apparatus, we are directly introducing an infection into the bony cavity, because shank spin itself crosses the cortex of the bone and enters the medulla, and the presence of the shank spin itself provides a pathway for the organisms to enter. Also, as with any other problem, always there are host factors which are responsible for either increasing the severity of osteomyelitis or increasing the propensity of a patient to contract osteomyelitis. These are generalized debility, hypoproteinemia, immune suppression in cases such as patients taking steroid therapy, cancer survivors, or patients infected with the HIV virus. Apart from that, there could be medical comorbid conditions such as asthma, diabetes mellitus, and tuberculosis, which themselves are an independent risk factor for osteomyelitis. Now, before we start off with acute osteomyelitis, let us take a look at what all can be inflamed or infected in the gamut of orthopedics. First is superficial tissue can be infected, that is called as cellulitis. You can have septic arthritis, which is the infection of the joint, synovitis, which is the inflammation of the joint capsule. Similarly, periostitis, which is the inflammation of the periosteum. Then our topic for today, osteomyelitis, which could be acute, subacute, and chronic, that is infection of the bone marrow. There could be infected non-union, there could be SSI, which is post-operative surgical site infections, and there could be infected orthopedic implants. This is the entire gamut of infection in orthopedics, which is of course a very important question answer topic. It is also an important Viva Voce topic. Moving on to the definition of osteomyelitis. Now, osteomyelitis can be split up into osteo and myelitis, which means infection of the bone as well as the bone marrow. Now, anytime you have an infection, the question is, how did the infection get there? How did it reach there? Now, osteomyelitis reaches the bone marrow through three different pathways. First one is through the bloodstream. As we spoke of, there is a rich vascularity and there is a high concentration of blood vessels. For this, there is a necessity that there should be a pre-existing septic focus in the body which is causing bacteremia or which is causing seeding of the infective material, including live microorganisms, into the bloodstream. So seeding of live microorganisms into the bloodstream and their travel into the highly perfused metaphyseal-epiphyseal region causing osteomyelitis is called as hematogenous osteomyelitis. An MCQ point here is that hematogenous is the most common mode of spread of acute osteomyelitis. Now, the next type is post-traumatic osteomyelitis. As we saw in the case of compound fractures or fractures treated with external fixators, it is after a trauma, either the fracture hematoma is exposed to the atmosphere, or because of the operative intervention which has been done, external organisms have been inoculated into the fracture site. And the third is direct contamination from a source which is physically close to the fracture. So there could be a septic arthritis which is complicating into an osteomyelitis, or it could be a superficial abscess which is complicating into an osteomyelitis. It is necessary that the source should be physically close to the bone and there should be direct seeding of the organism from the source to the bone. This is called as contagious osteomyelitis. Contagious osteomyelitis is generally one of the rarer types of osteomyelitis. Moving on, there has always been some debate about what is the duration of osteomyelitis. Now, acute osteomyelitis is one which lasts less than 2 weeks. Subacute is one which lasts between 2 to 6 weeks. This is fairly standard across all textbooks. The confusion comes as to what is chronic osteomyelitis, or more importantly, when does chronic osteomyelitis start. Now, some authors say 6 weeks, some authors say 12 weeks. There is a certain research paper which says that in pediatric age group, any osteomyelitis lasting more than 6 to 10 days can also be called as a chronic osteomyelitis, and therefore there is a lot of confusion about this. But what matters is the following line, and I request everyone to pay attention to this. That is, chronic osteomyelitis is a clinico-radiological diagnosis and it cannot be ascertained from duration alone, which means you must have the clinical and radiologic features of chronic osteomyelitis, that is sequestrum and involucrum, in order to classify a particular osteomyelitis as chronic, regardless of the duration to which it is been persisting. Now again, another very important place and a place where there has been a lot of debate is the causes of osteomyelitis, and everyone has their own set of causes, and here I am putting out some causes which are given in standard postgraduate textbooks of orthopedics. The first one is most common overall cause of osteomyelitis is Staphylococcus aureus. In case of infants, that is children less than 1 year of age, again the most common organism is Staphylococcus aureus. The next common is Streptococcus agalacticae, and the third most common is Escherichia coli. Now in children more than 1 year, again Staph aureus is more common than Streptococcus pyogenes and Haemophilus influenzae. This is one place which has attracted a lot of MCQs in the past couple of years, that is osteomyelitis seen in sickle cell anemia patients. The most specific organism to sickle cell anemia is Salmonella species, but even in these patients, Staphylococcus aureus is more common than Salmonella. Again, in patients who are immunocompromised or diabetes mellitus or patients having HIV, Staphylococcus aureus is more common than Pseudomonas species. And animal bite osteomyelitis, this has been asked in the recent years. Pasteurella species, the most common animal bite causing osteomyelitis, has been said to be cat bite. The organism is Pasteurella. Also, osteomyelitis which has been acquired in a hospital setting has been found to be associated with methicillin resistant Staph aureus, MRSA, and Pseudomonas. Now, three more organisms are here. First one is dog bite. The organism is Cytocapnophaga canemorsus. Next is human bite, which is Eikenella species, and rat bite, which is Kingella species. Now, the reason that I have drawn a line between these last three and the others is because the last three, that is dog, human, and rat, the research papers which give these organisms say that cellulitis following dog bite or human bite or rat bite has these species respectively. Osteomyelitis after these has not been reported, and the literature about it is very less. However, if a specific organism is asked, this is the answer. Moving on to pathophysiology of acute osteomyelitis. The most common route of infection, as we discussed, is hematogenous spread from a pre-existing pyogenic focus, which is seeding the infective material, that is rapidly dividing bacteria, into the bloodstream, which means not only is the presence of an infective focus necessary for hematogenous osteomyelitis, but also it has to be along with bacteremia. Now, once there is bacteremia and there are infective microorganisms in the bloodstream, there is entry of the infective embolus from a larger vessel into the bone. The portal of entry, of course, is the nutrient artery and the metaphyseal and the epiphyseal vessels. And at some point, as the arterial tree bifurcates, the septic embolus will stop at the mouth of a particular branch which is smaller than it. So it is entrapment of the infective bolus into an end arteriole. Now, once the infective embolus has trapped itself into an end arteriole, two things are going to happen. Firstly, it is going to start dividing over there and the infective embolus will start increasing in size. Secondly, what is going to happen is that because the embolus is sitting on the mouth of the blood vessel, it is going to block the blood supply, and therefore the blood supply to the area which has been supplied by that small end arteriole will be cut off. We will get to this in some point. Before we forget, there was a set of scientists called Phimeister et al., and they have noted that the predisposition of any bone to acute osteomyelitis is proportional to, firstly, the size of the bone itself, which means larger bones are more likely to contract osteomyelitis, and the second is the rate of growth, which means both of these are a function of the size and the density of the vascular bed which is involved. Now, this is a schematic diagram of a growing bone. Now here you can see that we have the epiphysis over here, we have the metaphysis over here, and here this entire white zone is the epiphyseal-metaphyseal junction, which is the epiphyseal cartilage. Now I'd like to draw your attention to this area which has been circled by the green box. If you can see, there are two things which I'd like you to pick up over here. First one is that the very high density of vasculature over here, it is much higher than the rest of the bone. Secondly, what I'd like you to see is that the arteries go all the way up to the epiphyseal plate, and take an acute bend or a hairpin bend before they merge with the venous system. So the arrangement is not a diffuse sort of arrangement, they are hairpin endings of blood vessels. So continuing with our pathophysiology, the metaphysis, as we saw, is the most vascularized area of the bone, and therefore it has predilection to infection. Second is the hairpin pattern of vasculature near the epiphyseal-metaphyseal junction. So imagine this vessel which is entering the epiphyseal-metaphyseal junction and taking an acute turn. Now this point of the vessel is the place where the vessel is likely to kink, or where the vessel has the smallest diameter, and therefore if an infective embolus is entering the blood vessel from here, it is likely to get lodged somewhere here just prior to the smallest diameter, which is the kink, and therefore the far end of the metaphysis bearing the hairpin bends of the metaphyseal vasculature is the most common histologic zone of onset of acute osteomyelitis. This is another MCQ point. So now infective embolus is now in the blood vessel. Not only is it dividing thanks to the rich blood supply, but also since it is blocking the blood vessel, the area supplied by that small end arteriole will suffer from hypoxia. Followed by that there will be a local necrosis. Now this is a necrosis, the tissue is dying, and along with that, very close to it, there is the infective material, and therefore there will be an infective necrosis. Necrosis itself will induce inflammation. It will cause release of inflammatory mediators. There will be debris which is lying around. There will be exudates, and these will cause a further necrosis. Now as the necrotic material keeps building up, it will exert a pressure effect on the nearby well perfused area, and slowly and steadily, because of the pressure effect, not only will the exudate build up, but also it will create a zone of necrosis around it, and therefore the vicious cycle goes on and on until a large zone of necrosis full of exudate is created. Now remember, this bone is a closed cavity, and therefore the exudate is under pressure, and therefore under pressure the exudate will tend to track, or it will tend to move along the path of least resistance. The path of least resistance inside a bone is the Haversian and the Volkmann system, which is a preformed set of canals, and therefore the pus will have a tendency to track into the Haversian and Volkmann systems until it reaches the surface. It will burst through the periosteum and it will form a subperiosteal abscess with collection of purulent material in the subperiosteal space. Let's draw it. Here is our local zone of necrosis. If you can see, this is a localized area, and it is the area supplied by one end arteriole. So if we were to theoretically trace the arteriole which is supplying this area, at the mouth of the arteriole somewhere here, we will find the infective embolus. Now as and when this site of initial necrosis goes on expanding, it will go on occupying more and more area, and because of that it will exert a pressure on the nearby normal bone, which also will slowly start to necrose. See these arrows? This is how it goes. Now as and when it starts traveling, it will travel through the entire Volkmann and Haversian system, and somewhere it will enter the subperiosteal space, causing a subperiosteal abscess. Now at the same time, there will be a larger zone which is devoid of blood supply, and it is en route to becoming a necrotic zone like this. Therefore, this is what we refer to as the vicious cycle, where necrosis will cause further necrosis until the entire bone is necrosed. Now, subperiosteal abscess not only has the signs and symptoms of inflammation, but also it is stretching the periosteum, and therefore this will cause severe pain and signs of infection and inflammation. We will get to the clinical signs in some time, and this is a long-standing case of acute osteomyelitis, where not only is the subperiosteal zone involved, but also the subperiosteal zone has been breached, and there is a sinus which is draining all this infective material onto the skin surface. Now these are changes of chronic osteomyelitis, and therefore the next important MCQ point is the most common complication of acute osteomyelitis is chronic osteomyelitis, and this here will go on to become the sequestrum. Moving on, now in some joints the periosteal attachment of joint capsule is away from the metaphyseal area. It is in the epiphyseal area. In some joints like the hip joint, the joint capsule covers the metaphyseal area as well, and therefore tracking of pus can also enter the joint, and therefore it can cause a septic arthritis. The most common joint to be involved in septic arthritis secondary to acute osteomyelitis is the hip joint. Similarly, as we have seen before, necrotic material is bursting through the bone into the subperiosteal space, causing a periosteal abscess, and then it is bursting through the periosteal abscess into the soft tissue. It will complicate as cellulitis before it bursts through the skin and becomes an abscess. Now, clinical features. The most common age group is infancy to early childhood with a very solid male predisposition 4:1. They are most commonly seen in poor socioeconomic strata which has low hygiene and protein deficiencies. Some of them may be immunocompromised, and often the patient will give a history of trauma. Often there could be a prior source of infection such as an abscess or a carious tooth. Now, this is a picture which we all need to keep in mind. Please note the calor, rubor and dolor, which is the swelling, and this is a case of acute osteomyelitis / cellulitis, and osteomyelitis clinically mimics acute cellulitis. This is probably the most important factor to be kept in mind. Now, in findings, we will have firstly there are symptoms of acute systemic inflammation. So there will be high fever, the child will be irritable, there will be tachycardia, vomiting, convulsions. Vomiting and convulsions will be secondary to the electrolyte abnormality caused by dehydration and the overall hyperdynamic circulation. A standard blood count will show leukocytosis, electrolyte abnormalities, and there will be an increased hematocrit secondary to dehydration. Locally, we will have the symptoms of acute inflammation, that is calor, rubor, dolor and functio lisa, and it may mimic either cellulitis or an intensely inflamed local abscess. So there will be local tenderness, excruciating pain, and because of the intense inflammatory response, the muscles around will be in a state of protective spasm, and therefore the patient will not allow any passive range of motion, which means if the examining doctor tries to move the joint, it will be limited by severe pain. If there is a subperiosteal abscess which is complicated into cellulitis, all the features of cellulitis will also be present. Moving on, if there is a well-defined cellulitis with a subcutaneous abscess, then signs of abscess such as soft tissue signs and fluctuation would be present. If there is septic arthritis such as in the hip joint, then decreased range of motion and and there will be increased pain as is seen in a septic arthritis. Now, the importance of all these things are that this is an ongoing high volume systemic inflammation, and therefore it may rapidly progress to septicemia followed by septic shock and death as a result of acute respiratory distress syndrome or multi-organ dysfunction syndrome, and therefore this scenario needs to be treated urgently. Now, the imaging, this is a plain X-ray. Plain X-ray is the first investigation to be done in a case of acute osteomyelitis. Now, as we can see, this is an X-ray of a pediatric skeleton. On the right-sided tibia, in the proximal tibia, what we can see is a lytic or a lucent shadow in the proximal tibial epiphysio-metaphyseal junction with irregularity of the cortex on the medial side, with another lucent shadow here indicative of a necrotic buildup. Also, since there is a breach in the continuity of the bone, it is likely that it is a ruptured subperiosteal abscess which has complicated with cellulitis. Now, another reason to suspect cellulitis is if you see the width of the soft tissue on the unaffected side and the width of the soft tissue on the affected side, there is a gross soft tissue swelling which corroborates our diagnosis of a soft tissue inflammation as well. Now, this is a slightly less advanced osteomyelitis seen in a pediatric distal end radius X-ray. Please note the epiphysio-metaphyseal junction with the lytic area which is secondary to the necrosis. This is a knee joint X-ray of the same patient as we spoke that there is increased vascularity which can cause multifocality. This is a multifocal osteomyelitis with the second focus being at the epiphysio-metaphyseal junction of the medial condyle of the femur. Now, one thing I would like to put across here is that all these three X-rays are x-rays of pediatric skeleton, and please make this a visual memory that children of single digit age group are the most common candidates for acute osteomyelitis. Now in other imaging, these are pure MCQ points. USG shows ultra juxtacortical soft tissue swelling with periosteal thickening. This is one of the first investigations to come positive. Also, USG is the investigation of choice if you are suspecting septic arthritis. Technetium 99 bone scan is the most sensitive and it is the earliest to give a positive result. However, it is not very specific because Technetium 99 bone scan only picks up areas of high metabolic activity. It cannot differentiate between infection and aseptic inflammation. Third, CT scan is not diagnostic, but it is a good tool to guide aspiration, especially in deep cavities such as pelvic osteomyelitis. Investigation of choice for hematogenous osteomyelitis is MRI with gadolinium contrast. It will show hypointensity in T1 and hypointensity in T2 and short tau inversion sequence or STIR hyperintensity. Now management, we require aggressive resuscitation. Remember, this particular condition is going to present as an acute systemic failure or acute sepsis, and therefore aggressive resuscitation, fluids and broad spectrum antibiotics to prevent the patient from going into septic shock is the first line of management. Followed by that, now the question comes, which antibiotic do we choose? The antibiotic of choice is penicillin and cephalosporins. Now if there is a clinical suspicion of methicillin resistant staph aureus, or if the institute is one where methicillin resistant staph aureus is common, then vancomycin or clindamycin may be considered. Now the surgical or the definitive treatment is emergent incision and drainage of subperiosteal abscess. Along with that, we have to perform metaphyseal drilling, which means a drill bit is used to create multiple drill holes in the metaphyseal region. This creates a path of least resistance and opens up the cavity so that exudate can easily flow out. Now once all these drill holes have been made, a small 1 by 1 centimeter bone window can be created in order to let the exudate flow out without resistance. Now there has always been debate on whether curettage should be done or not, but the current literature is against performing curettage. This is another MCQ point, especially the all except type of MCQs, that curettage should not be done because curettage tends to open up vasculature, be it endosteal or periosteal vasculature, and there is a risk of causing further seeding of the infection. So curettage should be avoided, and once the window has been created, this can be left to heal by secondary intention. Remember, this is a metaphyseal area full of spongy cancellous bone, and because of that, healing by secondary intention will occur. Now most of these areas where metaphysis is involved are close to the joint, and therefore muscular spasm secondary to the pain may cause the muscle to go into a contracture and later lead to flexion deformity of the joint, and therefore casting or splintage should be provided to maintain the joints in as close to a functional position as possible. And of course, once this exudate is collected, culture and sensitivity as well as histopathology must be sent, because acute osteomyelitis and Ewing's sarcoma are clinical mimickers of each other, and in orthopedic oncology it is always taught that you should biopsy what you culture and culture what you biopsy, and therefore the sample should be sent for culture sensitivity as well as histopathologic examination. And once that is done, antibiotics as per the culture sensitivity with the lowest minimal inhibitory concentration should be started until the patient is clinically stable. So this was the management of acute osteomyelitis. Get in touch with me. My contact email is in the channel information. You can add me on Facebook or Instagram, and you can always leave comments for feedback or criticism. And most importantly, like, share and subscribe, and put it across to all your friends, and hit the bell icon so that you can get notifications the next time I upload a topic. Thank you very much and have a nice day.